Hello, everybody. Thank you for taking the time today to listen to this presentation on the revenue cycle in healthcare. My name is Alex Armock, and I'm currently in the Master's Program for Healthcare Administration at the University of St. Augustine. The information shared today is pulled from the HFMA Unit 1 and 2 Certified Revenue Cycle Exam Prep. I'm shortly going to be certified in the revenue cycle, and I hope this presentation gives the executive team here insight into the importance of this topic within our organization. Before diving into the presentation, I would like to give this quick overview. Going through this list, you will realize that you may know some of these terms, but we will be focusing on incorporating them into the revenue cycle. On the next slide, I will briefly go over the revenue cycle in its entirety. Then we will go over pre-service, time of service, post-service, healthcare dollars and cents, the HCA-HPS, consequences of errors, key players, compliance, ethics, volume to value payment models, financial reports, accounts receivable, Medicare, Medicaid, TRICARE and Indian Health Services, commercial indemnity plans and self-insured plans, liability coverage and managed care plans, and then in-network versus out-of-network coverage, and then price transparency. So first off, we have to cover what the revenue cycle even is. So there are three main areas to it, and this includes pre-service, time of service, and post-service. This means that all the major steps that must take place to process a patient's account from the time they walk into the organization to when we close their account, meaning their balance is at zero. In the pre-service part of the revenue cycle, patient communication and data collection are key for this. Best practices should always be used when we are communicating with patients about their copays, deductibles, or if they are interested in any financial assistance. Collecting all of this data is important because it affects everything else down the road with accounts receivable and then the collection performance, which you are all familiar with. The next part of the revenue cycle is time of service. And I'm not going to lie, there is a lot that goes into this part of the revenue cycle. To start off, there are two types of patients within this topic, scheduled or non-scheduled. Scheduled patients are ideal because pre-registration is complete, which includes what we talked about on the previous slide. And then on the other hand, there's unscheduled patients, which we have to go through the long registration and all the financial processing when they show up to their appointments. Other things that are involved with time of service are the orders being entered, charges being generated, diagnostic and procedural coding being complete, results being reported, and planning for case management and then discharge. So post-service is the final segment for the revenue cycle. This includes any activities that would occur after the patient is discharged. So final coding, preparation and submission of claims, processing payments, and then balancing all the billing must occur at this stage before we close any record. Before we go any further, I just want you guys to remember that the patient is always top priority. The revenue cycle can be a lot of foreign language for patients, but we want to make sure they are engaged and satisfied. Things to consider are, do they have ease of access to our services? Do we have top tier quality when going through the revenue cycle? Do they know their options and pricing? And are we decreasing their cost as much as we can, making them feel satisfied about their entire experience in our organization? Now, how do we make sense of healthcare dollars? Being the executive team, you guys should know that the patients aren't the only ones asking questions about price. Employers, health plans, public officials, and others want to know where they can get the best value with their money. Patients aren't the only ones looking at a computer like this, trying to figure out pricing. We are doing that as well. Our organization should be training everyone appropriately when talking about healthcare dollars. We need to know when the best time is to bring up financials with a patient. Is there a different conversation when dealing with a routine versus a complex complex patient? And what do we do with those patients who don't have healthcare coverage? In addition, our employees should know how CPT or MSDRG codes work and how to check prices that way. How do we talk to insurance companies with codes to see what is covered? Overall, the patient should know what coverage they may have and what they could possibly be responsible for if remits come back with no or little coverage. The Centers for Medicare and Medicaid Services created a program that evaluates patients' perspectives on hospital care. This is called the HCA-HPS survey. We should be using this to see how patients feel about parts of the revenue cycle they may take part in, including registration, billing, collection, and other activities. In the future, we can prevent loss of revenue looking at these surveys. For example, we could dismiss patients passing information to the public on social media if we catch any concerns they have and then act upon it. On this slide, I will be covering potential consequences due to errors. And yes, these will happen even though we really don't want them to. So with billing, payments will be negatively affected if patient info or insurance policies are wrong. Delayed payments will occur if an incorrect plan is assigned to a patient's chart. Another consequence is the valuable time we will lose trying to collect the correct information and then the time spent resubmitting the claim again. In addition, we could have a delay for any needed medical equipment if anything goes wrong with misinformation. The final consequence with billing could be obtaining no payment or only partial payments, which we do not want. Speaking on legal issues, errors can happen from obtaining the wrong name, using duplicate name patients, or just having the wrong medical record. This is why asking date of birth, the last 4 of Social Security, addresses, and insurance are huge identifiers for patients. So you may be thinking, who even takes part in this revenue cycle? So here are 6 important key players. Physicians determine the needs for services. They write the orders. They schedule appointments and do any authorizations. Their completeness and timing are huge in the revenue cycle. They begin the revenue cycle, which impacts reimbursement and patient satisfaction. Skilled nursing facilities are in a separate wing of organizations. They are actually covered by CMS if the patient requires skilled nursing services on a daily basis, or those skills can only be provided on an inpatient basis, or if the services must be reasonable for the treatment of a patient's illness or injury. In addition, they must follow advanced directive provisions and have a written agreement with 1 or more hospitals for the transfer of patients from the hospital to the skilled nursing facilities. Home health agencies must have qualifying services, for example, physical therapy or occupational therapy services. They must have policies, clinical records, and licenses, and the patients must be confined in their home. Hospice is another key player. They are providing care to terminally ill patients. These individuals have to elect this care through Medicare and services including nursing care, physician services, medical social services, and counseling. Assisted living facilities are for those who need help with everyday tasks. Medicare does not cover the cost of assisted living, which is very important to know. Individuals do have access to their services 24 hours a day at these facilities. And then the last key player is durable medical equipment, which is prescribed by a doctor for use in the home. And this can include walkers, hospital beds, diabetes testing, or CPAP machines. Now, compliance is the best topic when it comes to the revenue cycle, and it should be everybody's best friend. All of you might think you know everything about HIPAA and compliance because of the regulatory training on it, but how does this play a part in the revenue cycle? This is very important because if staff slips up, our organization could be perceived with potential fraud or abuse. Risk areas include upcoding, incorrect coding, unbundling of services, duplicate billing, and waiving deductibles. The list can go on. This is huge for the Chief Compliance Officer. looking at you right there, we must make sure we have a corporate compliance program and that we follow it. This should be overseen regularly. And then having this plan could save the organization large sums of money because it can insulate the organization from violations and then lessen the effect of a potential event. On top of written procedures, we need the training to continue as much as it does and have a hotline where employees can report any compliance issues they might run into. Now, ethics are moral principles that govern our organization's behavior. Here are some ethical situations that may arise: financial misconduct, overcharging, theft of property, falsifying records to boost reimbursement, and miscoding claims. Here are two examples. So financial misconduct could happen if the business office coordinator at an office forgets to close the cash drawer for 2 nights in a row, making all of the statements not collected in a timely manner. Another example could be theft of property, meaning someone taking office supplies home for their kids to use at school, which is taking money and property from the organization. On this slide, I will be covering volume to value payment models. This is actually a huge transition in healthcare at the moment, us going from a fee-for-service model to a fee based on value services. These are 3 models that are trying to increase their setup to volume to value. Most of you know the law that was implemented in 2010, the Affordable Care Act. This act rewards greater value, improves the quality of care, and increases efficiency. They also encourage price transparency, improving physician quality reporting, and reducing hospital readmissions. The CMS innovation is an ongoing development of new models for delivery and payment of services, and these improvements could actually reduce Medicare spending by more than $15 billion. Accountable care organizations are a system of physicians and hospitals who work collaboratively to manage and coordinate care of a patient population. What's cool with ACOs is that if they meet benchmarks in the organizations, then receive a share of those savings. Many of you have probably heard of accounts receivables, and there are different ways to measure your AR, known as key performance indicators. The DNFB is the portion that identifies where patient services are completed, but the provider has not been able to bill the claim yet. It is best that we set a 3-day window that allows for the completion of the coding, charging, and insurance verification for the suspense period. The FB&S is where claims sit for additional additions to happen before releasing it to the health plan or government payer. And we really want this indicator to be close to 0 because this should only be used as a safety net. And then finally, our denial should be less than 2% when we are submitting claims. So financial reports are a huge part of the revenue cycle, and they must be completed and presented to the public to be used by others. These reports must follow certain regulations by the Securities and Exchange Commission, the Financial Accounting Standards Board, and the Generally Accepted Accounting Principles. Gross and net revenue are financial terms you might be familiar with, and then some other areas on a report could be explicit and implicit price concessions. These constitute the difference between the total amount billed and the amount that a third-party payer or a self-pay patient has committed to pay based on an agreement with the provider. Bad debts represent what patients do not pay or cannot pay, and that is not collected from the patient. Charity care is care provided to a patient who does not have the ability to pay for the services, which we would know this beforehand though. In this final section, we will cover typical plans we may see in our organization. It is important to know all of these and how the billing and compliance rules may affect our revenue cycle. So Medicare is a government-sponsored program which is financed through taxes and general revenue funds. There are many compliance rules with Medicare. For example, when someone is at a hospital, the diagnostic services must happen on the date of inpatient or during the 3 calendar days preceding. The only reason this wouldn't be true was if there was no Part A coverage. If this window is violated, it means the entire claim starts over, costing extra money and time, which we do not want. It is important to note that Medicare is secondary payer if the patient is working aged, is in for an accident, has end-stage renal disease, or is disabled. Right when we figure out Medicare will not pay, we must advise the beneficiary that they will be fully responsible. Our physicians must also know about modifiers and when to use them. These reduce the need for separate procedure listings on a bill. They also have specific billing rules that must be followed to ensure appropriate payment through Medicare. So looking at this picture, you will see that there are 4 parts of Medicare. Part A includes inpatient hospital services, skilled nursing care, and home health care. Part B benefits are available for outpatient and professional service coverages, but the beneficiary must pay a monthly premium for this additional coverage. And then Part C, you might know it as Medicare Advantage. This is a type of managed care plan that includes both Medicare Part A and Part B benefits, and it can also include Part D benefits as well. And then finally, Part D is known as the Prescription Drug Coverage Program. Medicaid, on the other hand, is a federally aided, state-operated program to provide health and long-term care coverage for low-income individuals or families. So the eligibility for Medicaid benefits expanded effective in 2014 through a provision of the Patient Protection and Affordable Care Act. As states were providing additional funding, if benefits were extended to individuals under 65 years of age with incomes up to 133% of the federal poverty level. In this picture listed here, that is actually from 2020, and you can see that the state decisions were trying to increase it up to 138% of the federal poverty level. And then in addition, for the first time, low-income adults without children are guaranteed coverage through Medicaid. It is important to note that not every state has elected to expand Medicaid coverage in this manner. And then Medicaid also has its own specific billing rules that must be followed to ensure appropriate payment. TRICARE is another healthcare plan that is part of the United States Department of Defense military health system. So this plan provides uniformed service members access to high-quality healthcare services while maintaining the capabilities to support military operations. They also have their own specific billing requirements that are needed, and they have date deadlines as well. The Indian Health Services is within the Department of Health and Human Services, which is responsible for providing federal health services to Native Americans. Federal legislation requires that Medicare participating hospitals accept Medicare-like rates as payment in full when providing services to IHS beneficiaries. It is also important to note that IHS is a last resort payer, which is crucial. Commercial indemnity plans do not require prior auths, and they also do not have specific billing rules. Indemnity plans are usually reimbursing a certain percentage of the charges after the patient meets the policy's annual deductible. And then self-insured plans mean that the costs of medical care are borne by the employer on a pay-as-you-go basis. So there is no true quote-unquote insurance through this. The employer determines what services are covered, but these plans actually typically include a stop-loss provision to protect the employer from catastrophic claim losses. Liability coverage is an auto, home, or business insurance plan that may include a medical coverage clause that covers individuals' healthcare services if it's associated with any kind of accident or injury. And then managed care plans attempt to reduce costs through contractual agreements with providers and through care management initiatives. These are typically seen within our organization if people have PPO plans, HMO plans, EPO, or POS plans. When speaking with patients, you must understand the difference between in-network versus out-of-network benefits. In-network benefits include a group of providers that have a contract with a health plan, and they agree to accept the plan's contracted rate as payment in full for services. If the patient goes outside of the network for care, they will likely be paying more. And then you might wonder the benefit of our organization to be in-network with well-known plans. Medical providers join these networks to increase their patient volume. These health plan networks offer policies to employers and individuals that steer business to in-network providers. The incentives include lower co-payments, lower deductibles, or lower premiums. And then in comparison, if a patient receives services at a healthcare facility that's not contracted with his or her managed healthcare plan, their policy plan will pay out-of-network benefits. And then the benefit impact can range from a higher percentage coinsurance to zero payment, resulting in a higher patient payment responsibility. So if a patient still decides to come to our organization and they only have out-of-network benefits, they should sign a specific financial obligation form that clearly states that they acknowledged their out-of-network services and their agreement to pay for the difference between in-network and out-of-network liabilities. And then in this picture, it's an example of somebody going to a surgeon who is in-network compared to out-of-network. And then we are assuming that deductibles are met in this picture for both in and out-of-network charges. And you can see that the in-network surgeon, at the end, the patient is only owing $600 compared to going to an out-of-network surgeon where they would possibly owe $8,500. Getting to the price is a challenge for both patients and providers. Price is defined as the amount actually paid by the health plan and or the patient for a specific service. And this is very different from either cost or charges. With the advent of high deductible health plans, consumers and patients are requesting price and quality information as part of determining where they will receive their care. Therefore, providers have developed these processes and employ technology solutions to respond to these requests in a timely manner. And this is called the health plan response. With this, our system can give us up-to-date confirmation of coverage, including their network status, if they need any authorizations, what deductibles they have met, copays, coinsurances, out-of-pocket maximums, and diagnosis or procedure codes that are covered underneath their plan. So in conclusion, we should remember the main components of the revenue cycle: patient satisfaction, the key players within a revenue cycle, compliance, the consequence of errors happening, major plans involved, and then price transparency. Here is the HFMA website where this information was taken. I want to thank everybody from the executive team for attending today. I hope you learned some basics of the revenue cycle and can go use this information in your next staff meetings. So if anybody has any questions, I will be here to answer them. Otherwise, I hope you have a great rest of your day.